Record so that we get going. Welcome everyone to the National MS Society case conference discussion. We have two cases tonight, so we will need to be mindful of our time. We're very excited to have two people presenting. The first person, as you see on your screen, Michael Bradshaw from Brigham and Women's, will present a very interestingly titled case, Zebra Stripes on a Hippogriff. So we're very interested in hearing about that. And second, we will have Megan Esch from Johns Hopkins, and she will be presenting on B-cell depletion and infection in MS patient management considerations. So I'm very excited about both. So I'm going to turn it over now to Dr. Bradshaw, please.
Thank you very much, Ms. Costello, and thanks for having me. It's a real privilege to get to do this. I'm glad that we have the opportunity. So the case that I'm presenting, I've titled this way because I thought it was a clever way to communicate that it's an unusual presentation of an unusual syndrome. And I thought this was pretty clever, but as soon as I Googled it, realized that someone else has already figured this out. So here it is. That's pretty much it.
Hey, Michael, do you have your video on so we can see you and your presentation and get a flavor for the...
There, can you see me?
There he is. Oh, hi, Michael. Okay, great.
I am.
Fabulous.
Okay. Those are zebra stripes.
What is that?
But I have some.
Is that a hypogriff? Hippogriff?
Yeah, I guess either way you want to call it. Now, this is going to be important later on, but I don't want to take up too much time on this. But so I have no financial context or apparently original thought. But I do have a deep set respect for tradition, and I'm a huge Harry Potter fan. So I have a personal tradition of whenever a group of neurologists gets together, which heretofore should be known as a ganglion of neurologists. I have a sort of tradition paying respect to my mentors along the way. So Dr. McDonald at Vanderbilt was the chair for a long time, and during my grand rounds, we transmogrified him into this wonderful character. Eventually gained the high status of Dumbledore, in fact, which is saying a lot. And a few other professors there from Vanderbilt, Dr. Kirshner, Dr. Davis. This is a real picture of Dr. D'Onofrio. I didn't change that at all. And a few others I took some liberties with. So, and many of you may know Dr. Sriram, he's a neurologist at Vanderbilt, who always seems disappointed in me.
Yeah.
And not approve of it. And so I thought in the same tradition, Dr. Froman, for all that you've done to put this together, I want to thank you and award you the status of Gilderoy Froman.
Love it. Love it.
So, but I digress. So this patient was first presented in 2011. He was a 17-year-old man. He was of African and Caribbean descent, born and raised in America. He presented to the hospital with several weeks of irritability, insomnia, fatigue, depression. He had stopped taking his antidepressants when his family was away, and this sort of developed over the course of weeks after that. And then over the last week, he had a nonsensical, pressured speech. He was behaving unusually. He started having hallucinations, commenting that he saw his sister eating watches and all sorts of unusual things. And so his parents took him to the emergency department at that point. So he had a significant depression history, took some antidepressants for that, also had Asperger, was a very high functioning person. And 5 years before this, he had an episode of chorea that was called Sydenham chorea. It was a little bit unusual even by those standards, where it was many, if not maybe a year even before, after he had strep throat last. And he was also diagnosed with Lyme disease, both of which were treated with antibiotics. And while he had this Sydenham chorea, he had these abnormal MRI findings, and I'll show you those in a minute here. His family history was really unknown because he was adopted and he didn't use any drugs or have any unusual exposures prior to this episode. And really, on review of systems, no infectious symptoms, no Zika symptoms, no rash, ulcers, including scrotal ulcers, arthralgias or hematuria or anything else to really point us in a good direction. So again, to recap his course, he presented with several weeks of irritability and then insomnia, depression, followed by these hallucinations and bizarre behaviors. So this was thought to be primarily psychiatric in setting of his history and stopping his medication. And so he was admitted to inpatient psychiatry and given Thorazine. But he had a dystonic reaction. And so he was transferred to the Children's Hospital and admitted to the ICU there. He improved from that, but they investigated more. And so this MRI was done when he was in the ICU.
Michael, Pablo Zacharias.
Yeah.
Pablo Zacharias, question. So the 2011 is when he presented. So his supposed symptoms would have been 5 years before that. Am I getting the sequence correctly?
Right. Yep.
Okay, thank you. Thank you.
Yep. So, so this MRI was done on admission to the ICU. You see some flare hyperintensity in the left parietal area here. You see some more. These are all old, and on the right side as well. This is old from that that correlated with this quote-unquote Sydenham chorea. And then this here though is the newer stuff. This was new, but who knows how old it was. It was just discovered on this MRI. This kind of juxtacortical and even probably some cortical lesion in the left parietal area. So that really is his workup. He had an extensive serologic workup. He had a lumbar puncture, basically all unrevealing, 3 nucleated cells, but otherwise normal. They didn't send the IgG index, which I would like to see, but it wasn't sent at the time.
Hey,
and he had extensive infection.
This Elliot, this may be a little bit antiquated, but at the time when this came up, was there a discussion about the spectrum of sort of the PANDAS disorder, or do we consider that sort of passé now with this expanded set of this broad profile of antibodies to be looking at versus just the acronym of the pediatric autoimmune neurologic disorders associated with streptococcal infections?
Yeah, they had, back in his original notes from that first episode, a couple people had mentioned PANDAS, but it was there's a lot of hand waving uncertainty in the course because it was just atypical for everything.
Yeah.
But
the PANDAS, I was on a NIH committee that Audrey Penn had put together, and the ones that sounded relatively homogeneous, not just everything, as Elliot's implying, a lot of it we now know is probably other things. They had to have the strep infection, and when there was imaging, they usually was stuff in the appropriate areas of the basal ganglia, almost overlapping a little with Sydenham. So these lesions wouldn't be where the PANDAS, if you believe it exists, would be located anyway.
Mm-hmm. And early on, Michael, not to belabor this, but this sort of this crescentic, juxtacortical, curving around the gyrus, looking like approximating the U fibers. Occasionally when this comes up in a different setting, perhaps in a patient with an immunodeficiency, whether that's drug-induced or it's genetic, some people might make the argument in terms of, is this the kind of lesion we might see, for example, in a PML lesion, obviously with a T1 hypointensity, but as they become more confluent, affect the U fibers and move around, sometimes that becomes a consideration, just a very kind of conspicuous abnormality moving into that U fiber around the gyrus. But okay. Yeah,
and he was tested for JC virus by PCR in the CSF and was negative, and also had herpes virus testing in the CSF, and really an extensive and appropriately extensive infectious workup that was all negative. He did have an autoimmune encephalitis panel that was sent, and these take a couple of weeks to come back, so that was pending. And he had an EEG. This is now a couple weeks into his hospitalization, and still quite ill. He had nonspecific slowing without epileptiform changes, probably what we most commonly see in just about anyone who's admitted to the hospital, it seems.
Exactly.
And he progressed. He developed this extreme agitation, alternating with episodes of decreased movement. He had dyskinesias and dystonic movements and became catatonic, and then started having tachycardia followed by bradycardia and some other autonomic instability, hypoxygenation, and they thought at the time that he was having, this was primarily psychiatric. So he actually underwent ECT, but he wasn't improving as they thought that he should be, and so they, the diagnostic box was reopened, and someone sent TPO and thyroglobulin antibodies that were moderately elevated. I think that was kind of the first clue that led them down the next pathway. And I thought this was a really beautiful.
Could you say a little bit of something about that autonomic instability issue? Was there any evolution of structural lesions identified on the MRI that might have implicated, some of the localizations we talk about as being sort of central zones of, autonomic instability foci? Sometimes we'll see cerebral T waves, we can see brady-tachy, we can see pressure instability in terms of autonomic, and of course we can see autonomic instability in things like Guillain-Barré. We can see it people who have the ganglioside antibodies, preganglionic autonomics in the spinal cord. But what about this autonomic instability? We didn't think this was drug related per se. Was there a CNS correlate to that, do we believe, either structurally or functionally? Would we be implicating one of those like parietal zones?
Yeah, and so this is a good question. There wasn't a lot of the description of his autonomic instability beyond episodes of tachycardia, bradycardia, and some low oxygen sats, all in the setting of him being mostly autonomic. But there is an MRI to discuss in just a moment, so I'll show you that, and that'll be important for this.
Okay.
But I thought this exam that someone had written was really beautiful. This was really at his clinical nadir, so he was at his very worst, and he was sleeping, wouldn't arouse the sternal rub, but then sits up spontaneously and moves around a bit, lays back down. Cranial nerves looked okay to them, but he resisted. He did this passive resistance to eyelid opening, which is typical in catatonia. He had some roving eye movements, and then he had some increased tone and diffuse hyperreflexia and basically sustained clonus in the lower extremities, but the toes were reported as flexor. So brain MRI was repeated at this point. Neurology.
By the way, that's the highest number of beats of clonus I've ever seen documented on an exam. So I congratulate you guys. You're as OCD at Harvard as I always thought you were. So 25 beats.
How long did you guys stand around and count it? My God.
You got the award on that one. That takes the cake.
I confess it wasn't me. I would have just said sustained but anyway, yep, that was pretty good. It seemed always said
it doesn't change the differential.
But right, it doesn't really change much. So here's his brain MRI. This is at T2, and you see there's a subtle T2 hyperintense lesion in the right caudal medulla, a little bit here as well. And then this is probably the cerebral aqueduct. But as we come up a little bit, you see this very nice midline medulla lesion that was probably responsible for a number of his findings. This was missed, actually. The MRI was an MRI with SPECT, and they were really interested in these the paracortical, juxtacortical lesions that he had. So most of what they were looking at was up there, and this wasn't seen on this MRI.
This was
but
missed?
You see it on. Yep. And here you actually see that there's enhancement on post-contrast images. That lateral lesion has the area of enhancement, and the more midline medullary lesions are hypointense on T1.
Little black
so there we
hole.
go.
Yes.
Yep. And so he was treated. The presumptive diagnosis at that point with the TPO antibodies was Hashimoto encephalopathy. Although I think it's hard to say when someone's seeing someone up front, so not to be critical, but he wouldn't really be consistent with that when you look at the data. And he actually gradually improved.
Yeah, that antibody sort of tells you something immune is going on, but that's not the range you usually see. I agree.
Yeah, that was baby. That was an appetizer.
That's barely positive in our lab.
Yeah.
Exactly.
Yep. Agreed. A non-specific marker of autoimmunity that, in its way, in this case, was useful. And so he gradually improved, but then shortly thereafter had new.
I was going to say,
so
Sean,
I don't want you to spend much.
Had mentioned at a course that we gave together in India that even if you're at the Mayo, these things don't come back the next day, and that's a good way to sort of alert yourself to maybe while the stuff is cooking to try some corticosteroids, because 5 days, unless you got a very severe diabetic, is not going to hurt anybody.
Right.
Yeah. Oh, absolutely. And so this exam, don't spend much time on this because, they say a picture is worth 1,000 neurologists. So just suffice it to say he has abnormal cranial nerve findings, and his right leg was weak and he had some ataxia. But really, I want to show you, Ron Weasley here has a really great example of what this exam looked like, apart from being unconscious. So you'll see that Ron has an upper and lower facial weakness, so a lower motor neuron pattern facial weakness. And when you ask him to look to the left, this is what he does. So if you can't tell, he's not doing anything. He just stares straight ahead, but he says he's trying to look left.
Yeah.
He has a left gaze palsy. And you say, look to the right, Ron. And the right eye abducts, but the left eye doesn't do anything. And so I guess and you want to throw out what you think this is, or if you know what it's called.
Let me see how many people on the line can they count it up. Let's see. We have, hold on one second. Don't move. We have, oh, here we go. We have Asfena Sharani, the famous. What do you think, Asfena? Is she not talking to me? Dr. Sharani? Well, I know Galetta's on. I know he knows, but hold on, Lindsay.
In the text.
Lindsay Horton.
In the text.
How about Lindsay?
1.5. Asana mentioned 1.5 syndrome, and Megan Esch.
Yeah, but you gotta add. So 1.5. You got to be able to add though. But if you have a 7 plus a 1.5, you just have to do simple addition. So what's that?
Megan Esch
7
has
plus.
responded.
Yeah, 8.5. There you go. Thank you, Megan.
Yeah.
Brilliant.
He has an 8.5 syndrome, but it's really an 8.5.
Brilliant, Michael. Very
legs.
few people know this. This is kind of a new addition, but yeah, keep going.
Yeah, I'm a total nerd. I'm a Ravenclaw, so the nerd is allowed to run free. So this is his repeat MRI. This lesion in the medulla now is much more clear, and this was picked up with the exam findings. And really, this is the lesion to blame. And the dorsal and sort of left lateral pons and extending a little into the middle peduncle. And it extends upward as well, rostrally as well. And this is a little anatomy diagram that I made that just illustrates kind of the anatomy here of what's happening. And I don't want to eat into time. So this lesion is really quite eloquent, and it catches all the right fibers for this 8.5 syndrome. So it's a very nice example of anatomy.
So one thing,
and here it is on the.
Go back for one slide, Michael. You did such a nice job. I just want to make sure that for the rookies that are on the left MLF, but when we say the left cranial nerve 6, let's make sure we differentiate between the abducens or cranial nerve 6 nucleus versus the fascicle. Here's the only cranial nerve where a lesion in the nucleus gives you a different syndrome than the lesion in the nerve. So a left 6 nerve would give you just a lateral rectus, whereas the abducens nucleus would hit a direct projection to lateral rectus on that side, but then you cross to the other side of the brainstem and ascend in the MLF to the medial rectus subnucleus of 3 and then to medial rectus, and that's how you get the gaze palsy, hence differentiating the nucleus versus the fascicle lesion. So here we have a left abducens nucleus producing that same side left gaze palsy, but the left MLF gives you the right INO, and the one thing you have left is the right 6 fascicle, which gives you abduction of the right eye. The other one little piece of information is if you see these people, which your Harry Potter guy didn't have in the primary position, is that they have paralytic pontine exotropia, because with the left gaze palsy, your eyes would like to gaze preference to the right in your Harry Potter guy, but it turns out the only movement that's capable is that right abduction. So that's the classic story of paralytic pontine exotropia, trutropia. Yeah.
Yeah. So I think it's pretty simple to think about it in terms of localization, that it's on the side of the immobile eye or on the side of the gaze palsy. The 8.5 syndrome actually was coined by Eric Eggenberger back in the day now. And so I think it is an extremely interesting and great anatomical localization that you made, Michael.
And that, by the way, was Steve Galetta. Thank you so much. And for those of you on the line who don't know that, this year, Steve Galetta is the recipient of the A.B. Baker Career Lifetime Achievement Award in Neurologic Education for the American Academy of Neurology, which I nominated him for. So thank you for those comments, Steve.
Well deserved, Steve, and good judgment there, Elliot.
Congratulations. That's okay. You're
I'm
next.
sufficiently embarrassed. Thank you.
You're next year, Bob. Just wait. Anyway, beautiful work there, Michael, and love that link of the 7 wrapping around 6. That's really what we try so much to get our residents to understand, that these the trajectory of these particular track systems and fascicles really they're not static. They're quite dynamic in what they approximate, and that gives rise to some of these very interesting syndromes. So, okay, we'll just keep
make Malcolm Carpenter very happy. Looks like a diagram in his book.
Ah, yes.
So, and this is the lesion on the sagittal plane. It's important to notice that it extends up, and it's also interesting to note that it does seem to be sort of around the 4th ventricle there, kind of hugging the ventricle. He has some other lesions ventrally, and he actually had a number of cord lesions as well. And who knows how old these were, because they were not enhancing at the time, but these cord lesions were there, upper thoracic, lower thoracic, and right down into the conus. And you see on the axial section that at least this one is more centrally/ventrally oriented. So about this time, the NMDA receptor IgG comes back, and it's positive from the CSF, and that was sent to Barcelona. Aquaporin 4 antibody and the MOG antibody were both negative, and so the combination of his sort of demyelinating syndrome and NMDA encephalitis, both of which really clinically he met very nicely, gives us this overlap syndrome. And so that's the diagnosis. Now, he had some additional testing to make sure he didn't have some underlying tumor, and he didn't. And he got more steroids and some IVIG, and then was started on mycophenolate mofetil. And he improved with the IVIG and steroids. The mycophenolate, as I think everyone knows, takes 6 months or so before you really see much of an effect from that. So he improved slowly and discharged to rehab. But then while he was there, he worsened, and this lesion in the dorsal pons had extended a bit. I didn't show the comparison, but it extends further back into the cerebellar peduncle. So then he was retreated with IVIG and rituximab, and again gradually improved and was able to go home. And now it's been over 7 years since that initial presentation, and he's done very well. He's had no new relapses since being on rituximab every 6 months, and we're quite happy about that.
Beautiful, beautiful.
There was a paper on this topic that I think is very interesting, that Titulauer and Donmau, along with many others, did, and they sort of broke these patients down into a few different groups. One group was the combination of NMDA encephalitis and a demyelinating syndrome at the same time. The next group was one or the demyelinating preceding or following encephalitis. And then I think the most interesting part of that is the comparison to the NMDA control group. And so you see some of these patients had aquaporin 4 antibodies, some of them were MOG positive, some of them were what we used to call NMO spectrum disease disorder, what we may still call that, but I think we're getting more toward the more specific diagnostic terminology, like aquaporin 4 positive. And importantly, I think really almost none of the patients with the overlap syndrome had tumors, compared to about 36% of those with sort of the classic NMDA encephalitis. And again, the abnormal MRI, you do see some non-specific white matter changes in somewhere in the 30 to 50% of NMDA encephalitis, but they don't typically, without the demyelinating features on the clinical exam, you wouldn't really put them into the same category. So I think that's kind of the summary from that paper, and the kind of take-home message there is really that you don't know what the frequency is for this, how often it happens. In that study, it was about 3% of patients with NMDA encephalitis had some demyelinating overlap. And some of those were sequential, some of them were simultaneous, and that the overlap patients tended to be less likely to have a tumor. They also tended to do a bit worse, mostly from the demyelinating aspect of their disease than the
Like with
encephalitic patients.
department, yeah.
And
I
just
understand.
thank you.
Very good, Michael. So, Elliot looked great there. So, can we have the negative of that? It's probably worth a fortune. But at any rate, so shows you how old I am. I'm talking about negative. So the question, Michael, is, we all bandy about the term demyelinating. And one would assume in the MOG positive that we know that there is a correlation to demyelination. Probably is in the distribution in the clinical, but I mean, if you take aquaporin 4, that's secondary demyelination anyway. It's an astrocytopathy. So, it looks like demyelinating, but now I assume there were no pathologic verifications in that series by Dalmo and the others. So it would be, I don't want to try, but it'd be nice to know if somebody accidentally didn't know what they were doing and biopsied one of those to see what it looked like. Just curious.
Yeah, it's really demyelinating or not. I think that's a very good question. Yeah. And you're right, we call it demyelinating.
I can see it, but pathologically, you got to be careful.
Yeah, agreed. So it has a flavor of demyelination, maybe we should call it instead. One thing that was interesting is that they point out in the
associated with demyelination, but the other is not the aquaporin 4. So.
Yeah, it's an astrocytopathy. But they pointed out interestingly that the NMDA receptor is present on oligodendrocytes, and they sort of very loosely hypothesized that maybe there's some relationship there. But I think really ultimately pathological.
If you culture,
I haven't seen any evidence of
oligodendrocytes in culture will die if you feed them with glutamate through both NMDA, AMPA, and kainate. So they are not only on them, but they are functional, presumably both physiologically and pathophysiologically.
A great point. Hey, Michael, this was really beautiful and elegant, and beautiful integration of not only the overlap, but elegant anatomy and pathophysiology for the occasional presence of an ocular motor syndrome with some other cranial neuropathy. So it's a great teaching case for all of us to remember those pathways. As Bob said, Malcolm Carpenter would be very proud of you. So this is terrific, and be prepared for the invitation to write this one up. This is a great one to think about, because I know a lot of people might look at that lesion, particularly that syndrome in the floor of the fourth ventricle. It's one of these areas of periventricular inflammatory demyelination, which is relevant and has concomitants, whereas a lot of the supratentorial, northern exposure at the periventricular zones often don't have corresponding clinical concomitants. They're not eloquent, but these areas are. So important to remember that this can occur as a concomitant of one of these so-called non-oncogenic cell surface antigen antibodies, which we link as these limbic encephalitides, glycine, Casper, NMDA, kainate, and others. So great one to think about. In a woman, we would say...
The neuroanatomy, Elliot, I think the neuroanatomy MRI combination is worth the publication just to show that off. It's independent of the...
Totally agree. And, we see it, in the anatomy textbooks theoretically, but here you've got a beautiful example of a guy with the facial and the 1.5. And I love comments, by Steve.
And the leaders that go with it, right. Absolutely.
So this will be a great one to put together. And I'm sure we'll find a way to put the Harry Potter part into this. Maybe we can work on the primary position paralytic pontine exotropia. We'll have to get approval from Galetta, but we'll make sure he reviews that. So beautiful job. And I think, as Kathy mentioned at the inception, we have a second patient. So I know Megan is waiting in the wings, but congratulations, Michael. Your mother would be very proud of you, and tell her I said so. I hope she's around. Mine isn't. I wish mine was, but so let's go to the second one. Kathy, do you want to transition over to Megan?
Yes, I've just given the presentation over to Megan, and she can begin to share her screen. And Megan, please feel free to come on video as well. And thank you very much, Michael, for that excellent presentation. That was really terrific. There she is. Hi, Megan.
Hi.
Hi, Megan.
Can you hear me?
Perfectly.
Wonderful. Okay. So the case that we decided to present is a less interesting case. It's more of a classic MS case. But we really wanted to have a discussion regarding management considerations in patients that are on B-cell depleting therapy and perhaps present with infections. Unfortunately, I don't have any pictures of my faculty advisor dressed as Harry Potter, but he is on the line. That's Shiv Saida. So he might have some things to say as I
Megan,
present.
let me just say before you start, this is not less interesting. This is really important. I know a bit about what you're about to present. This is very important. And Kathy and I discussed just this last week about, having a bit more of the presentations really dealing with formidably challenging management or complications to management issues. So this is a very, very, very timely presentation. This is not less interesting. This is totally centrally germane to what we do. So congratulations for deciding to show this. We all really appreciate this.
No zebras or hippogriffs. So no disclosures to report on my behalf. The objectives and kind of outline for this presentation, given the frequency of the use of, sorry about that, B-cell depleting agents in the treatment of relapsing or progressive MS, we should understand that serious and often life-threatening infections may occur. So I'd like us to consider while I'm presenting how we should proceed with disease management, especially in the setting of patients who have recurrent infections, but who also may require aggressive MS therapy and perhaps have been tried on a number of lower efficacy MS therapies preceding the escalation to B-cell depleters. And then secondly, how might we approach de-escalation of therapy after rituximab has been, or ocrelizumab has been initiated if patients develop recurrent infections. So this is my patient. She's a 56-year-old right-handed Caucasian woman who had a previous diagnosis of Raynaud's. She also had diagnosis of neuropathy. And when she presented to us back in June, she had an existing diagnosis of multiple sclerosis. Her providers wanted some assistance, and you'll see why soon, but particularly with regard to the disease-modifying therapy. So a bit about her clinical history. It kind of began 16 years prior to her presentation to us. She had experienced some difficulties with her gait, significant sensory complaints, spasms, word finding difficulties, kind of the vague things that patients often come to us with, some presentation of dizziness, fatigue, pain. Over the course of the next 4 or 5 years, she developed a progressive painful sensory polyneuropathy and actually received IVIG for presumed CIDP. I will show you briefly why she probably didn't have CIDP. But then at age 40,
just the story itself. Sensory variants are there, and it's a large fiber neuropathy predominantly, so automatically you start.
And
Dave Kornblath will be proud of you.
You'll see one slide that he probably did. It was his EMG probably. So at 48 years old, she developed painful loss of vision in the right eye and was subsequently diagnosed with optic neuritis. Over the course of the next few years, she developed progressive decline in her gait, had a few falls, had poor sleep, cognitive complaints, and developed some bladder symptoms as well. By the time she saw us, she had progression of her painful sensory polyneuropathy with burning pain to the knees and elbows. Now, when she saw us, this was her neuro exam, so her mental status was actually very good. She had a right APD, some global disc pallor on the right, red desaturation. Her motor exam was significant for, she was fairly strong, 5 out of 5 in most of the muscle groups, but 4 out of 5 in the right hip and knee flexors, and also a little bit weak in the left hip flexor. Her sensory exam was pretty markedly abnormal. Vibration was impaired all the way up to the hips, and then I believe she also had some thumb involvement as well. Yeah, vibration was reduced at the thumbs, a little bit worse left compared to right, and her pinprick discrimination was markedly decreased as well. Her reflexes, she demonstrated brisk reflexes in the upper extremities. She had 3+ reflexes at the patellae with crossed adductors. And then her ankle jerks were actually reduced. And then the toes were mute or equivocal. Coordination exam was also impaired left compared to right. Romberg was positive. And the gait was ataxic, as one might expect from the preceding maneuvers. So this is her imaging data. So you can see that it kind of fits a pretty classic presentation. And then we have some lesions in the spine as well. I'm not sure if you can see my arrow, but the red arrows are there. She had some lesions throughout the spine. Her laboratory data, she actually had 2 lumbar punctures. So one prior to the diagnosis of MS being made. This was actually when they were working her up for this polyneuropathy. So it was reported to us as clean in 2010. And then in 2013, after the onset of the optic neuritis, she had a second lumbar puncture, which demonstrated, as you can see, kind of a borderline IgG index. And she had 7 CSF-specific oligoclonal bands. The rest of the workup was very, very unremarkable. And I can tell you that she actually also saw one of our neuromuscular specialists who worked her up for this sensory polyneuropathy, and he also could not find anything very significant. Another thing that's important to mention here is that she was GC virus positive, so we are already, and I actually don't know what the titer was, but that precluded the other neurologists who had been seeing her from starting her on Tysabri.
Hey, Megan, when you say the workup, was there EMG nerve conduction studies where was any evidence of either dropped F waves or prolongation and distal latencies? I know that she still had reflexes above and trace at the ankles, but any features that would be suggestive of a demyelinating polyneuropathy in any of the segments?
No, and they actually didn't do F waves or H reflexes. I can show you on the next slide. It was axonal, but this is that's okay. This is her OCT, so you can tell that the GCIP is pretty markedly and asymmetrically thinned on the right compared to the left. Her RNFL is also thinned.
Can you stop right there, because you're on the line and and you're at OCT Central and Shiv Saeed is on the line. But for the novices that are joining us who know a bit about, or they've heard about OCT, maybe you can just give us just a brief sort of segue into what are you showing us here? What have you captured and how have you done this?
So basically, this basically represents the fact that the patient has a past history of a right optic neuritis. She's got thinning both of the retinal nerve fiber layers, which is the RNFL. So you can see that you can't see the arrows that I'm using, but if you look at the RNFL segment over here, you can see that superiorly and temporally.
Your arrows are showing up, Megan. The arrows are showing it.
Okay.
Yeah.
So she's got superior and temporally thinning in the retinal nerve fiber layers. And on my screen, sorry, I actually can't see what's on the right side of my screen because this thing is blocking me. But she's got some temporal thinning also on the left. So you can see that on average, this patient falls below the first percentile compared to the normal retinal nerve fiber layer that you or I who have not had an optic neuritis would have. So she's very, very thin. And then the GCIP overall demonstrates that she's just got pretty significant thinning. If Shiv wants to jump in and correct anything.
The one point that I would make here is that a very nice presentation of this data is that this has clinical correlation along with it, particularly when you look at Laura Balser, Steve Galetta, and of course Peter Calabrese and Shiv Saeed's beautiful structural functional correlation with patients reading low contrast letter acuity, like at 1.25 or 2.5%. This patient on the right side, if you look at that macular cube analysis, and this average RNFL would have very, very poor acuity on low contrast at 2.5. Maybe lucky if that patient was seeing really any at 2.5%, probably would see none at 1.25, whereas that 86 on that left side at 2.5% might be seeing 30, 35. So of the letters on the 70 letters on the chart. Now, black and white, we usually can refract people, normal people, to see most of those. But, you know, normals at 2.5% and 1.25%, there are floor and ceiling effects. So with you, Megan, if you're normal, we'd say at 2.5%, maybe you're seeing 40, 45 letters on each eye. Shiv, I don't know if you want to make any comment. I'm only doing it because I know there are junior folks on the line.
Yeah, no, actually, oops. I'm getting a lot of kickback there, so maybe it's best if I do next time. 1 second.
Yeah, somebody's got to turn that off. Yeah, okay.
There we go.
Shiv, are you still there, Shiv?
I don't think it's me.
Okay, good. So you were going to say, Shiv? Sorry.
Yeah, actually, so Megan.
So, Shiv, if you have your computer audio and you're on the phone, sometimes that creates that feedback. I'm not sure if both happen to be on.
No, they're not.
No.
No,
Okay.
I'll just.
There we go.
I think I'll take chairman's prerogative and say, Megan, we can just keep going, except to say what we're seeing is not just interesting technology, but has direct correspondence with patient-reported visual outcomes on something as simple as low contrast letter acuity. That's my point. It's really relevant.
Great, thank you. So, and then as I promised, just one slide very, very briefly to demonstrate that, you know, her sensory axonal polyneuropathy was actually very, very mild. So she did show reduced amplitude pretty much throughout all of the sites that were tested. And then she also showed bilateral medium and ulnar compressive neuropathies. And then clinical history was also consistent with a small fiber neuropathy. Now, she actually refused a biopsy, so we weren't able really to characterize further what contribution the neuropathy was playing, but it seemed to be pretty clinically significant. But I don't want to stress on this because there are more interesting things to talk about.
Her velocities are actually pretty good.
Yeah, the velocities are good. It's the amplitudes that are mild.
Yeah, and that goes with axonal. Yeah.
Right. Excuse me. So on the basis of all of the things that I've just presented to you, the process was considered to be consistent with, you know, one distinct CNS and one distinct PNS etiology. So let me go over her treatment history with you because it's quite, you know, significant. So before 2010, kind of when she started complaining of these neuropathic type of features, she received IVIG for a presumed diagnosis of CIDP, which, you know, as you can see looking at the EMG, this does not fit with a demyelinating polyneuropathy. She received 8 rounds of IVIG and didn't have any clinical response. Once they started, you know, they got an MRI, they diagnosed her with MS. She received fingolimod, but she was having fevers, so they actually discontinued it. In the same year, they started her on Tecfidera, which was discontinued for a number of reasons, including anaphylaxis. She actually reported having her swelling of the throat, difficulty swallowing, difficulties breathing. I don't know at what dose she experienced that, but she had received enough doses of Tecfidera that she did demonstrate a profound lymphopenia. And then I didn't mention it here, but she did also have disease breakthrough. Then from 2011 to 2013, they decided to de-escalate her a bit, and they put her on Copaxone injections, but she was having injection site reactions, and so they discontinued that. They then decided to start her on Aubagio. She was on that for 2 years and had breakthrough disease. She demonstrated some thoracic cord lesions. I didn't have access to those MRIs. Her prior neurologist kept them. And because of the breakthrough, they decided that they would start her on rituximab. So after the washout period with the Aubagio, it was about 5 months actually before they got her started on the rituximab. And that was started in March of 2016. So I created this little timeline to walk us through what happened after she started the rituximab. So first, these are all of the doses that she received. So she had 6 total doses in March and September 2016, and then again in April of 2017. Now, along the way, in October, of 2016, she had this worsening gait and ataxia, which perhaps was related to the neuropathy, perhaps was related to the MS. Really uncertain. MRIs didn't indicate that she was having any breakthrough disease. But here are the interesting points. She actually developed some concerning infections. So about 6 months after the onset or the initiation of rituximab, she experienced recurrent pneumonias, which actually landed her in the hospital, and she developed an empyema, which required a thoracotomy and IV antibiotics as well for resolution of the infection. Went about another 6 or 8 months because she continued to have recurrent pneumonias along that time. They gave her the 5th and 6th doses of rituximab in April, but then she ended up having recurrent and refractory sinopulmonary infections. She developed dental abscesses. Thick-walled abscesses in the maxillary sinus, which required surgery.
Hey, Megan, my wife Teresa is sitting here and asked, what was the level of lymphopenia at the time when Rituxan was started? Was there a carryover, or was the lymphopenia resolved?
After the Tecfidera that was given in 2012, the lymphopenia that was seen with the Tecfidera, I haven't reported that, but if I recall, it's not included in my presentation here, but if I recall, her lymphopenia has resolved.
It did resolve, okay.
So, so these CD19s and immunoglobulins were collected by us. They were not collected by her primary neurologist. It was about in June 2017. This was her first visit with us. So we had obtained immunoglobulins to see if that could help point us in a better direction of why she was having these recurrent infections. And in fact, you can see that her IgG is mildly reduced. So we go by a normal of 700. And I can tell you that looking back in the Care Everywhere system, she had an immunoglobulin panel that was completed back in 2013. So a few years ago, but I can at least tell you that at baseline in 2013, she had normal IgGs. I believe it was at 850. But at the time she saw us again, she had reduction of IgG. And then we ended up checking her lymphocytes. So she was appropriately suppressed. This was 6 months after she had received the last dose of rituximab, the October values of 2017, and then 1 month later she had actually begun the slow process of reconstitution. And again in October of 2017 we repeated the immunoglobulins, and she still had decreased IgG, decreased IgM, and her IgA was normal, within normal limits.
The other thing on that, go back one, Megan, to that is the G1 and IgM are the ones that fix complement the best. And you're getting a lot of bacterial infections, and that may be the combination.
Thank you, Bob. Exactly what Teresa was just saying. Same thing. The subclass is important.
So this is where I want to talk a little bit about kind of the next step. So we have this 56-year-old female who's having some mild clinical progression, difficult to tell if it's related to the MS primarily, if it's related to the polyneuropathy. She had previous breakthrough disease on lower efficacy medications, and now she's experiencing these serious infections on rituximab. So I'd like to open the floor a little bit regarding management of these recurrent refractory infections. What would we do with the DMTs? And then finally a consideration of what we should do, and whether or not we should be screening immunoglobulin subsets prior to the initiation of B-cell depleting agents, or should we wait until the patient presents with an infection? Should they have a prior baseline? And then I'll give a little bit of a presentation on what other people have done.
Hey, Scott Zamville, Scott, could I have you jump in on this question of, if you look at the majority of agents we're using that have potential capability for suppression, whether it's Tecfidera, Aubagio, Tysabri, Lemtrada, which is more transient. Should we be doing IgG screens and subclass screens? And should we be armed for using gamma globulin when people have infections, or consider a rapid transition to a different DMT?
So am I here? Do you guys hear me? I
Yes.
came in on the phone. I'm okay?
Yes.
So answering one question specifically with ocrelizumab, we do baseline Ig subtypes. I mean, we're doing isotypes at the beginning. So we're actually getting immunoglobulin before we start. Just as a, I don't know results on patients that we're following on that, but we are. This patient's a little bit complicated because this patient was on DMS, and I'm not sure if the patient was on Tecfidera and was part of DEFINE or CONFIRM in the clinical trials, because remember, Tecfidera was approved in March 27th, 2013, and this patient either was in the trial or was getting Fumiderm, which is a combination of monoethyl fumarate as well as dimethyl fumarate. So, and then the patient was also on teriflunomide. So knowing sequentially whether the lymphocyte subsets are normal is important before everything is attributed to Rituxan later on. I think that is a problem, even though it was a good couple years that the patient's on rituximab. And I'll make one other point, and what Bob was saying about IgG1 and IgM fixing complement is also, when you're thinking of using ocrelizumab and rituximab, do not forget that these are two different medications, even though they both target CD20. Both are IgG1, but there are two mutations in the Fc portion of ocrelizumab that reduces complement fixing activity. So the mechanism of cell death with ocrelizumab is more dependent on antibody-mediated cell toxicity, cell-mediated cytotoxicity, than it is on complement. So the profile of the two different medications, the safety profiles may not be exactly the same.
So Scott, another way of saying that would be that the antigen-antibody complex with Ocrevus is more contingent on Fc receptor binding and reticuloendothelial clearance.
Right. That is a nice way to say it. Better than I said.
No, I'm just asking.
My point was more about the patient's own immunoglobulins. We've not done the subsets except for IgG4, but we do total IgG. At least I do when I do M&A. You might anticipate with rituximab that 4 might go down, IgG4, but the problem is the range for IgG4, I'm almost giving up doing it, is in our lab from about 2 to 200 and something. So the chances that you can find something consistent, unless you really have very free measurements. But I do get those as a baseline along with the TB, and I can't get in our lab the subsets of NK. I can get the total 56.
I think I'm making a mistake on that. I think we're just getting the IgG and IgM. I'm not sure if we're getting the absolute
I did
subset.
get the G4, Scott, out of interest because of some of the stuff that Kevin O'Connor's talked about it with Musk, MG, but I haven't seen a consistent pattern of IgG4. So, but I still get along with the total IgG M&A.
That gets into more complicated than I think is necessary in terms of one being a Th1 or pro-inflammatory. Yeah.
You're dealing with metabolism, not just lack of production, so it's very complicated.
And Megan, one thing that I think is critical if you're using Rituxan and concerned about infection, just to make sure we have this right, just like, in general, if we have a choice, all things being equal, and we had to use both plasma exchange and IVIG, as long as we've got both in play, we wouldn't give gamma globulin, put your 10 grand in and suck it out with plasma exchange. In the same way, I'd be careful because I would want to use Rituxan, let it circulate, do the killing, and then the question would be to come in with gamma globulin afterward if we were going to use it as an antimicrobial therapy. My only concern is if you have it circulating first before you put in Rituxan, you may have anti-idiotypic antibodies and you may abrogate the ability of Rituxan to do what it does. So the sequence of these things is got to be also very important.
So I think that's an important point. Given that we're almost at the end of the discussion, I want to get to that. So just very, very briefly, I just wanted to let you know of the literature review that I kind of dug through. As you can expect, most of the literature that's available regarding rituximab and the incidence of infectious complications is in the lymphoma population, is in the rheumatoid arthritis population. So these were some of the articles that I pulled that seems to have the largest number of patients considered. So it seemed that the overwhelming trend of all of these articles was that patients who were on rituximab therapy, not just receiving 1 or 2 doses as part of their rheumatologic or oncologic process, those were the patients who were at greater risk or had greater odds of having an infection associated with longer-term rituximab use. And then secondly, patients who had experienced any form of chemotherapy prior to or in conjunction with the rituximab also seemed to be at greater risk of demonstrating hypogammaglobulinemia compared to patients who had only received rituximab. And some of these studies that have been, some of these patients that have been looked at in the lymphomatous population, in the rheumatoid arthritis population, did have baseline IgGs. And it seems like it's kind of a mixed review of whether or not having a baseline hypogammaglobulinemia predisposes a risk for having a decrease in gamma globulins as rituximab is continued. So I wanted to show probably the population that is maybe most similar to ours. Also not a ton of literature on this, but there was a very small, five patients, 50 patients total, but 5 patients who developed severe infections with NMO. All of the infections were sinopulmonary, and all had been exposed to either azathioprine or mycophenolate prior to rituximab. These patients developed very, very severe infections and hypogammaglobulinemia. And the treatment that was suggested for these patients is they received IVIG concurrently with, like, mixed in with their rituximab. So they dosed the rituximab depending on when the B cells started to reconstitute, but many of them were actually receiving regular IVIG treatments between their rituximab treatments. And we actually had a small discussion at our institution regarding this one afternoon. And one of our providers also, in patients who have demonstrated hypogammaglobulinemia with recurrent infections, he will give IVIG kind of concurrently with the rituximab treatment. And when I say concurrently, I do not mean at the same time as the rituximab, but if they're requiring rituximab every 6 months prior to the B cell reconstitution, they will get their IVIG between dosing of rituximab.
Right, but not at the same time.
Exactly. And then, so I don't know if anybody, Elliot, you kind of commented on this regarding when to give the IVIG. I don't know if any of the other
I don't know that. I mean, it's a theoretical, but in theory you might then get serum sickness, but I've not seen that. We haven't. There's a recent paper in PLOS 1 from Anza Memon, who used to be our resident with us, and before that a fellow with Omar Khan, and they reviewed their patients. There were a few myasthenics. I must have about 20 myasthenics on rituximab, but Omar had a few, and he had a lot of NMOs and some MS, and they actually did not run into that many infections. I don't remember if they were as high as 25 or 30 patients total, but I think they had 1 or 2, but none of them were severe, and in none of them they, as I recall, and I'd have to go, the paper just came out. I don't recall if they had to give anybody IVIG. I came close on one myasthenic, but when I rechecked her immunoglobulin, it was back up to about 680, and she wasn't infected, so I didn't do it.
So at least from what I found, the immunology literature demonstrates that or kind of the accepted level at which to give IVIG is if you've had 2 or more recurrent infections with, and I can find this source. I'm sorry, I didn't actually cite it. 2 or more recurrent infections with immunoglobulins IgG less than 700 is actually the point at which these papers that I have shown here, that's the point at which they gave IVIG as well. And at least what
that's with infection, 2 infections. The question is, exactly a number that would scare the you-know-what out of you to doing, they're not infected, but I don't like IgGs of 200. You know, something like
I didn't see anything that would support that. So then I can say that at least in this lymphoma population, they demonstrated that the mean number of infections pre and post IVIG was significantly reduced. The same in the rheumatoid arthritis population, and then just kind of anecdotally in this NMO series as well, the number of infections were reduced after the IVIG was administered. And then we all know this data. I can, show you that, as we've already discussed, the rate of infections demonstrated, at least in our literature with OPERA and ORATORIO, was not significant. So while it doesn't seem so far that it's something that needs to be a big concern, I think that we do need to have kind of a game plan for our patients as we start them on some of these more aggressive therapies, because the infections that at least we're seeing can be pretty serious. Requiring a thoracotomy for an empyema is not just a walk in the park. It's not your average URI. So understanding how to manage these things, I think, is pretty important. So this patient actually did receive monthly IVIG starting in January of this year after her sinus surgery. Her B cells began to reconstitute fairly well. So in February of this year, she was almost back up to normal. And as she started to reconstitute, we went back to kind of a very old medication and started her on Avonex. So far, she's reporting that she isn't feeling very well with the Avonex. She's having fevers and flu-like symptoms despite some kind of pre-meds. So she's actually she was supposed to follow up last week, but she's coming back in to see one of our PAs on this Thursday. So we'll see how she's doing. And I don't have any data regarding what her immunoglobulins look like now.
By the way, Megan, question, has there been any work using antibiotic suppression in any of these patients like we would do with recurrent UTI patients, where they're just not getting better with vitamin C and with cranberry and water and vinegar, and then some of these patients end up getting put on antibiotic suppression. So, and by the way, some of these infections, you're quite right, are serious. So the question would be not like an uncomplicated UTI. Some of these really would require bigger bullets in terms of specific antimicrobials. But has there been any work looking at that?
I did not see any data regarding prophylactic antibiotics or chronic antibiotics in patients with infection.
You might make the argument that IVIG is broader spectrum, whereas if you make a choice on an antibiotic and you've got a resistant bug, you're
going to get a resistant bug for sure if you do that.
You're screwed. And the other thing is, the patient you present is so interesting because it's fertile soil for this kind of problem, and somebody who's had lymphopenia, has been on multiple, I'm just going to say suppressants, not modulators. We've learned the hard way. We like to differentiate them, but that's really a fiction in our mind. So, and we're seeing this increasing.
One exception.
Yeah, go ahead.
DA is not a suppressant.
Yes, you're correct. Glatiramer, yes. So I think the point you're making is a great one, because we're not only seeing people who have had significant lymphopenia, but just people transitioning between these agents and then arriving at a drug like Rituxan that, what you've done as the antecedent, plays a role. It's not irrelevant. And, we should really be more systematically collecting this data and seeing patients who are going through these switches, not just the ones that, pique our interest because they've had significant and serious infections. I'll bet that there's a whole bunch of these patients that are just not being reported.
So Megan, I think that's a very good point about keeping our eyes open as things go forward, because remember that OPERA 1, 2, and ORATORIO are not 5-year studies.
Right, exactly. So still to be determined.
It doesn't go down much quickly, but we're putting these people on it for the next 5-10 years, and I've got some myasthenics who are on 6 or 7 years of this, and knock on wood, so far I've gotten away with it, or they've gotten away with it. But that's a very different thing than, a 2-year study, and wouldn't expect much to happen. Plasma cells live a long time, but eventually they got to be replaced with B cells maturing, and if you're killing them off, it's an issue potentially.
Right.
So there's,
Yeah.
can I say something? It's Scott here,
Yeah.
and just two things. One, as Bob's pointing out, we don't have the kinetics. We don't have a long-term sense of going out 5 years. That would be nice. The other one is to keep in mind that in OPERA studies, in other words, 1 and 2, the population is different than what we're dealing with here, that we're taking care of our patients. And to keep in mind, we don't like concomitant immunosuppressive medications. And to think that when we do it sequentially, that in some sense, they really are concomitant. So the pharmacodynamics of somebody who's been on Tecfidera, who switches immediately to ocrelizumab for breakthrough activity, so for all intents and purposes, is on both therapies. And I think that's a real problem in dealing with patients. I try and wait till people reconstitute. The drug that scares me the most lately is actually Tecfidera. In fact, I like Tysabri because it doesn't leave a signature. 3 months after we stop, or 4 months, or 5 months, the patients are where they would have been before.
There's another theoretical question I have for Scott before we make it too long. So the one drug that, we wait until the lymphs are back. There's sort of a guideline if they've been on Fingolimab. If you have cells trapped in the lymph nodes, will they see the rituximab or the ocrelizumab in high enough concentrations? It's a theoretical thing. We know with rituximab, with Sjogren's, sometimes there's evidence that you affect the lip biopsy. So the argument is yes, but we know that. It's just sort of an immunologic Talmudic point. How many angels on the head of a pin?
But it's
That's a great
theoretical one, and it's practical because we do worry that if we take somebody from Fingolimab who's breaking through to go to ocrelizumab, that they're not going to see as much drug. Remember, there's a compartment effect when we're giving either rituximab or ocrelizumab. The first, we know from either animal studies and where you can do it more easily, blood and bone marrow get depleted first. The other tissues are more resistant. So secondary lymphoid organs and parenchymal in the brain don't see, and germinal centers in lymph nodes for B cells, they don't deplete as well. So in other words, what you're saying is a real question, that when you start ocrelizumab or rituximab on someone who is on Fingolimab, who has a total lymphocyte count that's around 200, where the B cells are only going to be half of that, you don't know. I
think your point about Tysabri is not only do you know it's out of the system, but the cells are sitting out there as a willing target in the circulation because they can't get out.
Hello, exactly. And as a last point, I would say, and this hasn't come up, here you're giving a therapy, Megan, as a regular maintenance, whatever it is, every 6 months, or when your CD19 is approaching 1 or 2%. But I would put in a plug here at the end to think about, you've got a long time, as Bob says, after 2 years, where are we at 3, where are we at 5 years and beyond? These diseases don't go away. But if you think about the mechanism of anti-CD52 therapy with Lemtrada, you've got that window of concern, that 1 to 2 year period, but when you're done, you're done. Reconstituted your immune system, you can be on antimicrobials, revaccinate people, and in a substantial proportion over time, you may be done. You have other things to look at, but this is often a therapy that rarely comes up in these discussions. I'm not exactly sure why, since we're removing a fundamental component of the autoimmune heritage of these patients across the spectrum of immune-mediated diseases, and probably dramatically reduce the risk of things like PML and recurrent infections because of the reduced requirement for recurrent dosing. So,
but you are removing, Elliot, the quote, or resetting the autoimmune, if you consider MS proven autoimmune. I won't get into that argument, but you're somehow, and at the last meeting of ACTRIMS, Alistair Coles got up there and said, we still don't know why, you're now introducing more other autoimmunity, true autoimmunity, ITP, thyroid, God forbid, an occasional Goodpasture glomerular. So there's probably that, and the black box warning where people are worried about unknown malignancies, I think is along with the price of the drug, is probably why you're not seeing a lot of it.
But remember, there's the Froman whack-a-mole study where when the CD19s are coming back, we give like immunologic labetalol, super low doses of Rituxan, 25 to 100 milligrams, and until we see the CD3 cells coming back to their baseline, which you've measured 2 to 3 months before they started therapy, then let them synchronize. And in the patients, 37 patients we've done with this, different time frames, obviously, after the infusions, we've not seen yet a single secondary autoimmune disease. So we'll see what happens with that.
The other last point to make, however, is at least in the phase 2 study with the ofatuzumab, for the point of view of the patient's MS, the lowest dose, which did not eliminate all B cells, worked as well as the 2 higher doses that eliminated all B cells. So it'll be interesting to see phase 3s.
That's a great
Maybe you don't
point.
have to get rid of all of them. We don't know.
Great point.
Good point.
Megan,
I think, great job.
Great job, Megan.
And let me tell you, just as interesting as this is really important. This is the neurotherapeutics pragmatics 101, and we've been waiting for a presentation of this type really since the beginning in September. So
very good. Well, if you want more, one of our nurses is presenting a little case series at CMSC regarding our experience with some infections in rituximab. So stop by her poster.
Everybody go take a look at Memons Anz's paper with Omar and Alex Ellis and Chris Kahn and some of the crew, because again, not huge numbers, but a little bit more optimistic. I may have one of our fellows go back and look at my pure myasthenia experience, because they've had a lot longer. And some of them, to be fair, have had previous immunotherapy. I mean, we use azathioprine and Elcept and those drugs a lot more widely than we see in the CNS patients.
I think we'll go ahead and conclude there and thank both Michael and Megan. These were two fabulous
work, guys. Great work.
Thanks everybody for tuning in and all the great comments.
It's snowing here in Detroit. If anybody's interested in a fair weather country, we got a little snow.
Yeah, sure. All right.
Good night,
anyway,
everyone.
Let me once again thanks Kathy and the Society for supporting, and Scott Zamville for being the matchmaker between the Society, this program, and Neurology N2. So we're very excited in going forward, and want to thank Uncle Bob for popping in and his always important comments about these issues. It's really been fabulous. Thank you so much, Bob. And I see that Andy Goodman and others have joined us. I'm going to have to rope them into our future conversations. But this has become a really, really special second Tuesday of every month. So thanks to you guys. Great presentations.
Good night, everybody.
Good night.
Everybody.
Good night.